Now, to our main event. Dr. Jerilynn Prior is an award-winning endocrinology clinician scientist and professor at the University of British Columbia with over 45 years of expertise. Known for her groundbreaking work on estrogen-progesterone balance, Dr. Prior's innovative approaches are transforming the understanding and treatment of women's reproductive health. In 2002, she founded the UBC Center for Menstrual Cycle and Ovulation Research, and in 2003 launched its informative website, www.semcor.ubc.ca. Dr. Prior is an internationally recognized thought leader with over 300 influential publications on menstrual cycles, ovulation, PCOS, perimenopause, menopause, and osteoporosis prevention. Growing up in an Alaskan fishing village, she earned an honors MD from Boston University in 1969 and became a Canadian citizen in 1983 due to her belief in universal health care. So let's give a warm welcome to Dr. Prior.
Thank you very much. I thought I would start by a few slides just to share, and I hope I can share my slides.
Yes, Libby
so
or
we're
Ilana,
on the
can you give
same
her
page.
permission?
Are you allowing sharing? I don't.
Yeah, just give me 1 second
Okay.
here. You should be able to now.
I tried to shut down everything. I don't see where. Share, okay. Share.
I can see it.
All right, slideshow. Why doesn't it go that way? Here we go. Let's try this one. There we go. So this time, instead of talking about menstrual cycles, we're talking about perimenopause and menopause. And I have to start off by saying that I'm no expert in diabetes. I know a lot about perimenopause and menopause, and as someone who's interested in hormones in general, I can hopefully help you have some way to understand what's going on with blood sugar and those kind of things. I have no conflicts of interest, and I think progesterone is beautiful. Plus, I'm ever so grateful to live on the lands that have been protected by the Coast Salish peoples for generations. First of all, about perimenopause, I'm showing you an old Gary oak. Now, Gary oaks are unique to the Gulf Islands in British Columbia. And this is an ancient one, as you can see from the tortuous limb here. But perimenopause is like this picture in people wrongly thinking that we're old. But in fact, it's a new beginning. It's springtime like the flowers behind show. So perimenopause is an extremely poorly understood thing that is more like the end of a fireworks show than it is like most other things I can imagine. So why do I say that? Because instead of one follicle being the primary hormone producer for a given menstrual cycle, there are multiple follicles, all in different stages of growth, happening at once. It's out of control. Now, we need first to talk about what the words mean, because menopause is used at least in 3 different ways. So you ask about any woman, and she's likely to say menopause is all about that negative stuff, that changing and getting old. If you ask a gynecologist, the surgically trained experts in women's reproduction, they will assert that menopause is the literal final menstrual period. But if you ask an epidemiologist or an endocrinologist or someone who values science, they will say menopause is women's final life reproductive phase that begins a year after the last period or menstruation. And I think if you are hearing me, you will see that often this word is used wrongly or used in different ways, even in the same article. So when someone says menopause, ask what they mean. So the official World Health Organization definition of menopause is the phase of life that begins a year following the last menstrual flow. Okay, the other thing is that perimenopause and menopause not only are confused in how they're called, but they're confused because they do share some symptoms. They do share infertility, and in perimenopause, that is relative and it's absolute in menopause. They share hot flushes and night sweats, and they often share sleep problems. But they do not share mood swings, depression, anxiety, breast tenderness, mental fog, trouble concentrating, heavy flow. Those are things that go with perimenopause only. And we recover from those when we hit menopause. Now, what's even more interesting and important to talk about is that there are a whole different set of experiences as you go across perimenopause. So all of this is perimenopause. Some of it is called the menopause transition, but the whole thing is called perimenopause. It can start with things like night sweats that come about around the time of the period in women whose cycles are still perfectly regular. It can start normally as young as age 35. We call it early menopause transition when cycles become irregular. And we call it the late menopause transition when we have skipped the first period. And the final menstruation, we don't know is final until we've been a year. And by that time, we've graduated into menopause. That is about age 52. The age approximately at the first skipped period is about 48, at least in North America. So let's go back to perimenopause a minute, because I said that it was like the end of a fireworks show. Boom, 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 boom. Here's evidence by levels of estrogen, and you don't have to worry about the numbers, in women who were basically going of different phases in perimenopause. And actually I can't see the far right, which has been 3 to 12 months without a period. But each of these dots is an individual woman's blood test. All of the levels were taken close to flow, in like the first week or so after a period. And they should be right around this lower horizontal line here. However, you can see that they're not. These are women who were above 42 years of age and had regular periods. Look at how high they go, because this is as high as the estrogen level should get at the middle of the normal menstrual cycle. I think you can see that there's higher levels all across perimenopause. So that's a really, really, really important point for understanding your blood sugar. You can't predict when your period is going to come. You can't predict what insulin dose you might need. And I mean, I don't have diabetes, but I was so hungry in perimenopause. I was so hungry. I was raiding the refrigerator on the floor where I work. I mean, several times I ate something and then had to bring it from home to replace it because I was just too hungry to work. So this time of chaos that is perimenopause is a time of instability when insulin requirements and here's another peculiar thing. Remember, we talked about a pattern of a high estrogen, which is the solid dots here, and then progesterone starting. And this first cycle here is a little bit on the short side and is a typical very early perimenopause cycle. But now there's a delay. So this woman is into the early menopause transition, and her estrogen goes up as one would expect, about the same as her previous cycle. It starts to go down as it should. All of a sudden it goes sky high again, really sky high, enough so that when she has a really very inadequate progesterone level down here, and then gets flow while her estrogen level is still very, very high. That's one of the reasons for very heavy menstrual bleeding in perimenopause, a high estrogen level at the time of flow. Usually it is decreased by that time in the cycle. Okay. So I talked about perimenopause and high and very variable estrogen levels. Let's talk about progesterone levels. And instead of levels now, we're looking at the length of time from when an egg is released until the next flow. So here's the turquoise levels are the cycle lengths, which are about 28 to 30 days. And the yellow bars are the luteal phase lengths, which is the time progesterone is high. And these data were from a single woman when she was regularly ovulatory. She had 2 screening cycles, and then we followed her for another 12 cycles. Only once during that whole time did she have too short a time of progesterone in what's called a short luteal phase. But here she is 10 years later in perimenopause, and not a single one of her cycles taken at the same time of the year. You can see that her cycle length still is regular, and she's still within the normal range for cycle length, but now she's not ovulating normally at all. All right. So estrogen's high, progesterone is lower, and not only lower, shorter luteal phases, but shorter progesterone levels. And what's happening in the brain? Well, the brain is reacting to chaos. So every time estrogen level that's swung really high goes down, there's a huge brain release of stress hormones, neurotransmitters. In fact, everything we can measure goes up at that point in time. And most of those hormones will be anti-sugar, insulin resistance producing hormones. And we know already that it's estrogen downswings that are related causally to night sweats and hot flushes. We also know that they're related to bone loss and to depression. So the combination of really out of control, high swinging estrogen levels, plus higher stress hormone levels because of what estrogen is doing, plus higher stress hormone levels because we're changing from being reproductive women to being non-reproductive women. And that's a social status change that's not positive in our culture. So there are multiple reasons why blood sugar and insulin control might be difficult in perimenopause. So what are the symptoms in perimenopausal women? These are data from a random sample. Actually, the blood sugar levels I showed, not sugar, estrogen levels I showed you before were from the same random population-based study. This is looking at things that over 30% of women experienced in perimenopause. So low energy across all the different aspects of perimenopause, depression increased around the time of the skipped period. Headaches were pretty bad across. Aches and pains, again, got worse in the late menopause transition after a skip period and in the late perimenopause that last year. Sleep trouble was common and then got worse. Being nervous got worse also and then got better. Hot flushes got worse and continued into late perimenopause. Night sweats got worse and then worse yet. And breast tenderness in exactly the opposite. And if breast tenderness, as I told the premenopausal women last time, is a kind of a bioassay of estrogen effect, it started off super high. Many women experienced it, and it decreased as they got closer to menopause. So then the question is, are there things that will help with the symptoms in perimenopause? And I need to show you these data because you are not likely to be told about them by your physician. This is a randomized controlled trial that we did, which we gave oral micronized progesterone. It's the natural hormone that counterbalances estrogen effects. And basically we gave 300 milligrams at bedtime for 3 months. And at the end of and half of the women were on a placebo and half of the women were on the actual progesterone. At the end of 3 months, we asked them, what overall change in daytime hot flushes did you experience? And everybody said they got better. Those who were taking progesterone said were more likely to say they got better, but it wasn't a statistically significant effect. However, the overall change in night sweats was significantly different than placebo. Here's the value down here. We also ask about heaviness of menstrual flow. And what's peculiar is here's the median of the data. The average woman didn't experience any change in the amount of flow. And the same was true for how frequent their periods came. They didn't see any change, but they had markedly improved sleep on the progesterone. Here's the median here, and here's the improvement on progesterone. So that sets the stage to talk about perimenopause, which is the time when I suspect that those who have type 1 diabetes will have the most difficulty. So I will stop now and then we can go to questions.
Okay, question number 1 from Anonymous. Does the dose of insulin increase during menopause?
So we don't know what she meant by menopause. I would suspect it would definitely be increased in perimenopause, and I would expect that it would also decrease once she is in true menopause.
Okay, that was anonymous, but if you did ask that, would you like to follow up? Okay, next question. Teresa P. Do postmenopausal women still have hormone shifts? I seem to need increased insulin every 2 to 3 weeks for about 2 to 3 weeks, then shift to decreased insulin need again.
Okay, thank you for that question. I don't think if you're experiencing that it's related to the hormones of menopause. I think we have to find another explanation. Because by the time we've been a year without a period, with very rare exception, our levels of hormones are very low, both estrogen and progesterone. That's a planned steady state that I've been in for 20 years and that most of us will be in for, the rest of our lives.
Teresa, would you like to follow that up? Any questions? Okay, next, anonymous. I'm in perimenopause, and some weeks I am super insulin resistant in the mornings, pre and post breakfast, and other weeks I snap back to normal. And in other weeks I snap back to normal. I haven't found a pattern. It just has begun to work like this over the past year. Is that normal?
I think so. And what I would do to try to figure it out is to use this test of high estrogen levels, pushing the palm of your hand over your nipple toward your spine, and see if it's tender. That means your estrogen levels are high. See if you can make a relationship between your need for insulin and your high estrogen levels. See, my understanding is that insulin helps to allow the blood sugar to go into cells, but estrogen helps energy to go into cells. It's sort of store energy for later need. And therefore, when estrogen is high, we're likely to be storing, and that is a counter action to the action of insulin.
Okay, the person who submitted that question, would you like to follow up? Okay, we've got a couple questions in the chat box. Melissa asks, is it recommended for type 1s to take HRT, hormone replacement?
Okay. Now we're talking something slightly different. First of all, hormone replacement therapy is a drug marketing term. It isn't a scientific term. Because we're not replacing really the situation that we have as young adult women. The terminology should be menopausal hormone therapy. So then the next question is does it make you more healthy if you take menopausal hormone therapy when you're menopausal? And the evidence we have is it doesn't make you more healthy. That doesn't mean you don't need it if you have a reason to take it, like hot flushes, like sleep problems. In other words, it's a treatment. It's not a prevention. And you'll have to answer that question yourself. Do you need treatment? Are you suffering with night sweats and hot flushes enough so that you really need to take that hormone? Or are you okay?
Okay, Melissa, would you like to follow up?
Everybody's shy today.
Okay, so I actually want to follow up. So you said that taking hormone replacement or the treatment
Menopausal hormone therapy.
Yeah, menopausal hormone therapy doesn't make you more healthy, but what are the negative health implications, or are there any?
Yes, absolutely. There are negative health implications because estrogen increases blood clotting. Therefore, you're more likely to get a blood clot that goes to your brain, a stroke, etc., a blood clot that goes to your lungs. Also, there's increased risk for breast cancer. Obviously different depending on the actual mix of the hormones that you're taking. So in other words, it's not a trivial thing to try to bring your hormones to something like when you were 20, when you're older. And the evidence is it's not healthy if you don't need it.
So it sounds like the costs outweigh the benefits, because the benefits are more quality of life. Night sweats. I'd rather have night sweats than have an increased risk for stroke.
But the evidence is those who had the worst hot flushes in a very long study were more likely to have a hip fracture because night sweats go with that release of cortisol and catecholamines and stuff, which is hard on bones. And there's similar data that those who have the worst symptoms are more likely to have heart disease also later. So in other words, it's a benefit to take therapy when you need it, but it's a harm if you don't need it.
Okay.
That makes
Thank
sense?
you. It does. It does make sense. This question is in the chat box from Lauren. What are the exact name types of progesterone used in the study that you just talked about?
Okay, thank you. That's an important question. There's only one kind of progesterone, and the kind we have as a treatment is by pill. It's oral micronized progesterone, has many brand names. So if you just ask for micronized progesterone, what's different is that they're like little balls. They're not like a tablet. They're perfectly round and they bounce. So it's a very different kind of treatment than we're used to. And the reason they're round is because the progesterone is in a fat like sunflower oil.
Okay, Lauren, did you want to follow up? I know you had some other commentary, but I just wanted to let you express your own thoughts.
Okay, thank you. And I think I wrote that question, but now just kind of hearing your a few minutes ago about if you need it, like that. So then how do you find out what test how do you find out if you need it?
By what you feel.
Okay.
Yeah, it's not a test. There's no test. It has to be your experience. And here's a guideline that I learned. I mean, basically on my own and my patient's experience. And that is if you're waking twice a week with night sweats, that's an indication that you need treatment. What's interesting is that progesterone's major and basically only adverse or side effect is the helping with sleep. Isn't that funny? Usually we expect bad things, but in this case, it's a side effect that's a good thing.
Okay. And so the second part of my question was, and it's this idea I've heard that progesterone is the first, like you try progesterone first if you're having symptoms, which I'm hearing, and that balances, and then you determine if you look at estrogen, and then because progesterone is that balancer. I just wanted to hear your comments on that.
I think I haven't heard that before, but I think it is the right approach. And most people will not need estrogen to be added, and only added if they're menopausal. No estrogen in perimenopause, because your own is already plenty high, and giving more is not going to make that better. Okay.
Thank you.
Welcome.
Quick question in the chat box. For the study you referred to from Melbourne, which country is that Melbourne located in? And that would be Australia, correct?
I'm
Melbourne,
sorry?
Australia.
Which
Melbourne.
country?
The study
Melbourne, Australia. Yes. That
Okay.
was the study. The study I was talking about was here, obviously. Well, it was across Canada.
Teresa asks, is there a difference between progesterone cream and the micronized progesterone for heat and night sweats?
Yes. Progesterone cream is absorbed a little through the skin. We can't usually measure whether it's absorbed enough or not. So I don't think it's something that would be effective in perimenopause. There's no randomized controlled trial that it helps in perimenopause. And if you want to try it as a first go in menopause, that sounds like a reasonable idea, but don't try it in perimenopause.
Okay. Teresa, did you want to follow up? Okay, next question in the chat box is from Julie. I've been in menopause since December 2022. My last period was December 2021. Should I expect my blood sugars to continue to remain stable now that I'm in menopause and have left perimenopause?
Yes, 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 yes. And do you think it's improved? Can I ask you a question back?
Julie, you don't have to answer, but
You could put it in the chat. See, I want to learn because I couldn't
Oh, there we
find.
are. Can you
Hi.
hear me? Hi, sorry.
Yes.
Yes, I feel so much better.
Yay.
Yeah, it's just night and day compared to
Mhm.
probably about the roller coaster of perimenopause for the better part of a year of 10 years.
Yep.
So yeah, it's there's light at the end of the tunnel.
I almost became a type 2 diabetic in perimenopause.
Oh,
It
wow.
was a wake-up call for me.
Yeah. Yeah, it hits us in different ways, that's for sure.
Mhm. Well, I'm
Great.
glad you're better and you can expect to stay better. The point at which you get frail, where you're not exercising, not interested, you've got other medical stuff going on, is a point at which it might become unstable again. But you should be stable while you're a healthy menopause.
Thank you. Can I ask you one more question?
Sure.
I also read, I don't know where or when, but I read that women with type 1 diabetes tend to go into menopause earlier on average than women without. Is this
Mhm.
a thing?
It is, as far
Ah,
as I know, it is. And I think we're not totally clear. It may be because there's an autoimmune connection with type 1 diabetes. I don't know the answer to that.
oh, okay. I was just curious.
Mhm.
Okay, thank you.
You're welcome.
thanks, Julie. Next question in the chat box is from Susan. When and how should one discontinue menopause treatment, hormone
Oh,
treatment?
okay. Good, very good question. So the first question I need to answer that properly is, why did you start it? And those people who start menopausal hormone therapy for hot flushes as the main reason may have more difficulty stopping it than people who started it for, they thought it was going to make them healthier or something. They weren't symptomatic. So estrogen, remember I said the drop in estrogen causes night sweats and hot flushes? Well, the drop in stopping it can also cause them. Okay? And therefore, my suggestion is, if you're taking a progestin, medroxyprogesterone or something else, not little round balls with your estrogen, that you ask for a prescription for the oral micronized progesterone, 300 milligrams, 3 little round balls, and take off the progestin and replace it with the progesterone. Because progesterone has this calming effect on the brain. Then, very gradually, you can try it. No, I would still do it gradually. You know, about 10% less every 2 weeks until you can stop the estrogen entirely. And by then you will know whether the progesterone is adequate to control your night sweats and hot flushes or not.
Susan, would you like to follow up? Okay, next one is from, oh, go ahead.
She says there's a thing in the chat. She's down to 4 days per week, but migraines are being a problem. I would suspect that you're not taking the oral micronized progesterone. The first thing I would do is ask your doctor for that prescription. You are. Are you taking 300? Yes? Okay. So I think you need, what kind of estrogen are you taking? The gel. Okay. I think you need to go down more slowly, not skip some whole days in a week, but what you can do is the gel makes a thread of the medicine that's, so long. Decrease the thread by, a half a centimeter or something every day. Do that for 2 weeks and then try decreasing it a little bit more. Don't suddenly stop it for several days each week. See if that works. And if it doesn't, email me and I'll do my best to help.
Okay, our next question is from Karen. I had heard from other menopausal women that they are also taking androgen. Is it beneficial to take testosterone?
Very good question. So I need the answer, and you don't have to answer. I need the answer in general to a question. Do you still have ovaries? Because those people who've had, for some reason or another, both their uterus and their ovaries and hopefully tubes removed at the same time, or both, all of them removed, don't make enough testosterone for normal sexual activity, usually. And they need a little bit of testosterone. But those of us who still have our ovaries have enough testosterone. And there's little evidence that it's effective in helping with things like sexual function if you still have your own ovaries. Does that help? Just one ovary should be enough.
Okay, let's go back to the questions in the pre-submitted questions. This is from Sherry S. Can you talk about menopause and hair loss?
Okay. Hair loss is more likely in perimenopause. And again, what it can be is that normally we have, just like a forest, we have little trees and big trees, old trees and young trees. And we don't, but a plantation of trees that were all planted at the same time, if there's something that affects growth, then you have very obvious hair loss. That's something, it has a fancy name, Telum effluvium, which is really weird, but at any rate, it recovers. So that kind of stress-related hair loss happens more often in perimenopause, sometimes due to social or other stressors, but it isn't typical of menopause a year after your last flow.
Okay, I don't think Sherry's on, but if she is, do you want to follow up? All right, next question. I'm kind of hopping different topics, but next question is from Diane. Are the unexplained high blood sugars due to hormone changes? I feel like I'm a teenager again going through puberty.
Then I'm guessing you're in perimenopause, and I'm guessing you're very much right.
Okay, Diane, if you're on, would you like to follow up? All right, next one is anonymous. If I were to have a full hysterectomy and my ovaries taken out, how could this potentially affect my blood sugars?
Okay. The first while after having that surgery, you're likely to have, even if you take hormone therapy, you're likely to have instability and not be able to figure out for a while what level of insulin you need for the amount of food and exercise you're doing. So I'm hoping that you wouldn't have your ovaries out if you don't have a cancer reason for that surgery. But I would work very closely with someone who's an expert in diabetes if you need that surgery to help you manage the sugars afterwards, especially immediately afterwards. Does that help?
Not sure if the person is online. Okay. Stephanie, do you want to go ahead and ask your question?
Yeah, okay, sure. I mean, I put it in the chat, but I can say it. We talked about um you mentioned that you recommend only testosterone, let's say supplementation for people that don't have ovaries or fewer ovaries. But if we're losing testosterone from age 30 onward, and it's essentially a kind of the pro hormone for progesterone, would we not see improvements in building and maintaining lean muscle mass and building and maintaining bone mass too, bone density, I should say.
Okay, let
Like
me
I
let
think
me let me go
because I
back a bit, because yes, yes, our testosterone does go down in our 30s, but then it doesn't go down. It stays steady. We don't keep losing it.
oh,
And it is not a pro-hormone for progesterone. I don't
okay.
even know what that means, actually.
So it's not a precursor for other hormone production, estrogen or progesterone.
No. Well, no, it is a precursor for estrogen.
Oh,
It's
okay. So my
broken
mistake.
down. It's
I
broken down into either dihydrotestosterone, which is really the strong male hormone action, or estrogen. That's that's the body's way of getting rid of it. So it is a pro-hormone in a sense for estrogen. Certainly not for progesterone.
okay. So there wouldn't be any lean muscle mass benefits or bone density maintenance benefits or mood and energy or sexual function benefits to taking it.
Not if you have your ovaries.
Hmm.
Basically, the studies that were done, that were blinded and randomized, those women who were on testosterone were more likely to masturbate. And in fact, many of them were distressed at the feeling they needed to masturbate and not happy because it didn't improve their sexual function with a partner.
Hmm.
I think we
Okay.
improve muscle mass by good food and by exercising.
Okay, next question in the chat is from Julie. Is it common to have a breast fibroadenoma show up during menopause?
During perimenopause, yes, not menopause, right? That's why we started with the terminology. Perimenopause is the time when estrogen is too high and when it's variable. And yes, of course, breast masses, breast tenderness are hallmarks of perimenopause.
Okay, Julie, would you like to follow up? Okay, next one is from Colleen. What causes the brain fog? I feel like I have dementia sometimes.
Okay, I think this is not scientific. I think it's related both to the higher estrogen and to the high cortisol that comes when estrogen levels are dropping. We already know that cortisol or stress hormones prevent our laying down new memories. So there's a kind of a temporary dementia, if you will, that happens when we're under great stress. And perimenopause is a time of stress for multiple reasons and is a time of also high estrogen. And both of those things, I think, cause brain fog.
Okay, Colleen, would you like to follow up?
No, that totally makes sense. Thank you.
Okay.
Next question in the chat box or clarification, maybe she's asking for. Just to clarify from Melissa, it's expected that perimenopause lasts about 1 year, and as type 1s, we can expect a roller coaster blood sugars for this duration. Then we'll see stability afterwards during menopause. Is
Okay.
that
Yes to the last part of that. But perimenopause can last 10 years. I mean, I had bloody sore breasts for 10 years and didn't recognize perimenopause before that when I had heavy flow and other things that were changing. So don't expect perimenopause to be a flash in the pan. It takes a long while for many of us.
Melissa, would you like to follow up?
Hi. Perimenopause sounds terrible, so I just want to throw that out there.
Oh, well, we survive. Come on.
I haven't gone through perimenopause yet, so I'm just trying to prepare myself. And sort of what I imagine is, if anybody's ever had kids, for that 9 months, 10 months that we're pregnant, we try really hard to keep our blood sugars, really
Perfect.
tightly controlled. And
Yep.
I think we can deal with the difficulty for that year. And so I was kind of, hoping you were saying, well, okay, for a year in perimenopause, we're going to have these roller coasters, but after that, it'll get better. But I think what I hear you saying is it could last quite a bit longer than that.
Yes, it does get better as you get closer to menopause. In other words, you have more stability in the final year, for example, late perimenopause.
Okay.
You have to keep up hope. It's going to get better, even if it's miserable for a while.
Thank you.
Yeah.
Okay, the next question, pre-submitted. I think you might have addressed this, but there's no harm in reiterating. Can perimenopause and menopause be definitively diagnosed by a healthcare professional via things like lab tests?
Absolutely not. They have to listen to you. And when you say, this is what's happening with my periods, these are the things I'm experiencing, they should believe you. There is no blood test for perimenopause. And don't ask for an FSH and don't ask for an estrogen, because they're doing this and they're not going to be reliable answers. So don't waste healthcare dollars on it. Trust your experience, trust the pattern, the sort of timeline thing I've given you, and know you'll survive, you'll manage through it.
Okay, Colleen, I see your hand up.
Hi, so I am definitely in perimenopause, and I read the menopause manifesto, and I was like having all these, like, I have a lot of symptoms. And so I started HRT, but now I'm very worried because you said that that's not necessarily a good thing to be on during perimenopause. So what, like, what are the side effects of being on, I guess, MRT during perimenopause?
Menopausal hormone therapy. Yeah.
Yeah. Does it just make things worse, or because
It could make things very dramatically worse, because you could be having the estrogen in the menopausal hormone therapy and your own estrogen, which is already high. So it's going to go higher. It's not going to suppress your own estrogen, which is a fallacy of many doctors thinking that it basically what happens in perimenopause is the normal feedback that we talked about in premenopausal years is broken on purpose to let us get rid of all those follicles so we don't have a period when we're 90 in a nursing home. It's planned chaos. It makes sense, but it's not necessarily fun. So I mean, most gynecologists believe that there's benefit in perimenopause from menopausal hormone therapy. But I can tell you that I've searched the literature and there aren't any studies that prove that. It's well proven to be helpful for people with symptoms in menopause, no doubt about it. But in perimenopause, there is no evidence. And don't get me started on why all the guidelines say that it's okay. I mean, it's a scientific oops in the medical community.
Okay, thank you.
Okay, so you can stop the estrogen gradually. And if you need the progesterone for hot flushes and stuff, carry on. That's okay.
I actually have an IUD,
Okay.
so
But
for other reasons.
still, progesterone's job is to counterbalance the effects of estrogen in every tissue, not just the uterus.
Okay, I just saw something in the chat box. How long can we safely take MRT?
Menopausal hormone therapy can be taken, I guess, safely until you're about 10 years into menopause. After that, the harms begin to exceed the gain. And what I would do is, it's hard if you're on estrogen. If you're on progesterone alone, you can stop it and see what happens with the hot flushes. And if they come back at all, they'll come back very gradually. The problem is with estrogen. And when you stop it, the risk is the symptoms could get much worse. So I would try decreasing the estrogen gradually and see what happens.
Okay. Susan, did you want to
Someone was asking.
follow up? Because I see more messages in the chat box. Okay. From Judy, this is miscellaneous. I went into menopause at the same time I was diagnosed with type 1 25 years ago. Now I'm back to having hot flashes, sweats, and my tight blood sugar control is going out the door. I'm having to use far more insulin through my pump, and my sugars still run high, whereas for most people, most of the 25 years with type 1, I've struggled with lows. So basically, now she's struggling with highs.
I can't answer that, but I don't think we can attribute it to hormones. I think you need to look somewhere else. See if there's another hormone that's out of kilter that would make insulin resistance. If your exercise has changed, your weight has changed, I don't think it's likely to be due to ovarian hormones.
Okay, Judy, if you're on, did you want to follow up? Okay, Lauren, I noticed you asked a question about saliva tests and naturopath. Did you want to talk? I mean, did you want to talk more about that or ask? Because the other question you would ask was determining possible HRT needs, which I mean, MRT needs that
Right.
Dr. Pryor talked about, but
Did I pre-submitted that?
about saliva test from
Okay, I think
naturopath.
she's already answered it, and I know that there's no test.
Okay.
Okay. The other questions I don't think are necessarily pertain to menopause, but I'll just throw it out there. Anna says she's struggling to lose the last 5 pounds. How can I reach my goal? Is that, I mean, you do gain weight and
So the problem is that you've been trying to lose weight and you've hit a certain point and can't go lower.
correct.
First of all, it's important to understand that the body tries to preserve the level of weight that it's sort of gotten used to. And there's a whole bunch of protective things to keep you from losing weight. And so the last 5 or 10 pounds are hard to lose. And maybe you don't need to lose them. What you need to do is to stay at the weight you are, rather than try to aim for something that might be impossible. That's not terribly helpful, but I mean, it is the reality that the last few, especially if we're trying to go lighter than really our bodies want to go. In some ways, our bodies are pretty wise.
Okay, so this is the last question submitted. Are there any apps that track glucose and period phases?
Not that I know of, and we need them. I'm hoping some of you will start gathering some data and we can start making sense of the mysterious things that we still don't know. For example, someone who was type 1 diabetes as a premenopausal woman as a perimenopausal woman and as a menopausal woman, their data about their insulin requirements and their weight and their et cetera over time would be very valuable. It would give someone like me a better way of answering the questions, the important questions you're asking.
Okay, does anyone have any other questions? We've reached 7 o'clock, but I want to make sure everyone is asked everything that they wanted to today. Great. So I want to thank Dr. Prior. Thanks a lot. Every time you speak, you really give out a lot of knowledge, and I think we really appreciate it because it's a topic that very few physicians and gynecologists actually talk about too, as you said. And certainly endocrinologists are not readily just answering these questions or bringing up the topic. Okay. So this is our last huddle because we take a break in the summer. So it's great having you all on screen. If you do have things that you want to talk about starting September, let us know because we always try to respond to your requests. So thank you very much and have a nice night.
Have a good summer, everybody.